it's great to be here back in Uppsala. I started my research career here as a young PhD student many years ago. It's always good to be back. I'll talk about delivery room handling, past, present, and future aspects, but we are running late, so I'll try to shorten my lecture. And what I would like to do now is to show you how the present algorithm has been developed, and then I will say a few words about the very recent ILCOR recommendations, which were published just a week ago, very recently. I don't think I have any disclosures which are relevant to this lecture. Well, what is delivery room handling of the newborn? Well, I asked ChatGPT. It's good we heard about artificial intelligence. And the answer is the following. Delivery room handling of the newborn refers to the immediate care provided to a newborn baby in the first few minutes after birth. The handling is usually done by trained healthcare professionals, including obstetricians, midwives, nurses, and neonatologists. Now, what is the need of resuscitation? Excuse me. Well, we have some very recent data from Australia, published in the very recent ILCOR recommendations. So, out of 600,000 live-born infants, 10% of these needed CPAP, and about between 4 and 5% needed positive pressure ventilation. And 0.8% were intubated, and only 0.2 percentage needed chest compressions. Well, these are data from Australia. So here I think we have a more global overview of the need of resuscitation. And so what? Excuse me. So I think what everyone here knows is that out of the 130 million newborn babies, all of them should be assessed at birth. They should be kept warm, and they should be positioned correctly. Approximately 20 million newborn babies need some stimulation in order to start to breathe spontaneously. That is 15% approximately. And 4 to 6 million, that's between 3 and 5 out of 100, need some bag and mask ventilation. And as we heard already, for term and near-term babies, we're supposed to start with air. I'll come back to that. 2 million, 2 per 100 maybe, need endotracheal intubation, and 0.8 million, less than 1 per 1,000, 6 per 10,000 perhaps need chest compression and or adrenaline, and very few need volume expansion. Thank you. Thank you. Now, the need of resuscitation according to gestational age, this is from a European registry, the e-newborn. This is data we published some years ago, and it shows the need of resuscitation for the smallest babies between 22 and 32 weeks of gestation. And you see that the most immature babies, almost all of them, need some kind of resuscitation. But it is important to distinguish between basic resuscitation and advanced resuscitation. And you see that basic resuscitation, which is bag and mask ventilation, oxygen supplementation, is mostly needed for both babies around 32 weeks. However, for advanced resuscitation, where you also add intubation, chest compressions, need of adrenaline, epinephrine, you see that for the smallest babies, more than 90% would need advanced resuscitation. And is this of interest? Yes, because it seems that the prognosis, and that's not, of course, surprising, for those who need advanced resuscitation is poorer compared to basic, and this has been corrected for gestation age and birth weight. So it's almost a doubled risk of death if you need advanced resuscitation. So now a few words about the development of the resuscitation algorithms. So this is an algorithm from 1990 from Bloom and Cropley's textbook, and I will not go into details here. I don't know if you can read it. I can hardly read it myself here, but in 1990 it was recommended that if there was meconium aspiration or meconium, you should suction the baby, and you should suction through the mouth and then the nose. And it was also recommended to use 100% oxygen if the baby needed positive pressure ventilation. Now, so this was actually not questioned at all in the early 90s. American Heart Association, when they published their resuscitation guidelines in 1992, said that there's no reason to be concerned about using 100% oxygen for newborn resuscitation. And also during chest compressions, at that time there was 120 chest compressions per minute, and later it's been shown that this is almost impossible to follow. And also the use of sodium bicarbonate was very popular those times, and I myself, I have given tons of sodium bicarbonate to asphyctic babies. Today we know that that is probably not very healthy. It might be detrimental even. So yeah, this is just how you should position correctly the mask if you need to do a positive pressure ventilation. Now, just a few words about the development of the algorithms between 2005 and up to 2025. I myself, I had the privilege to take part in writing up the recommendation from year 2000. But in 2005, the algorithm looked like this. At birth, you were supposed to ask 5 questions. The first was, is the baby born at term? Is the amniotic fluid clear? Is the baby breathing or crying? Is there good muscle tone? And is the color pink? Now, color pink was removed, and the reason for that is that newly born babies are not pink. There's only one way to make a newly born baby, a few minutes of age, pink, and that is to give oxygen. So that was removed. If you answer yes to these questions, baby should have routine care with a mother. If no, you should evaluate respirations, heart rate, and color. If the baby was breathing, heart rate above 100 beats per minute, but the baby was cyanotic, you should consider to give oxygen. And at that time, it was mostly 100% oxygen. So if the baby was apneic or had a heart rate less than 100 beats per minute or persistent cyanosis, you should start positive pressure ventilation. And if the heart rate still was less than 60 and not increasing, you should continue positive pressure ventilation and administer chest compression. And if that was not successful, you should go on to give adrenaline and/or volume. And you see here you have A, B, C, D, and what was very difficult at that time, and I'm sure that Wally and many of you remember that, you had 30 seconds to move from one letter to the other, one box to the other, and that was extremely stressing to do that. So in 2010, Ilkor presented this algorithm, and I think this is familiar to all of you who are working with the newborns. Now it's only 3 questions you're supposed to ask. And first of all, is the baby born at term? Is the baby breathing? And how is the muscle tone? And now the timing was only the first 60 seconds, the so-called golden minute, which again was split up in 2 parts, each of 30 seconds. And what was new, which Akil also mentioned, was that in 2010, Ilkor recommended to start positive pressure ventilation with air and not 100% oxygen for term and near-term infants. So you should start ventilation if the heart rate was less than 100 beats per minute or there was apnea or insufficient breathing within 30 seconds after drying and stimulation. So this is what you are supposed to do. The first 30 seconds, the baby should be dried, kept warm, wrapped in plastic if it's less than, for instance, 28 weeks. You should stimulate the baby to breathe, you should position the baby correctly, and you should start to register heart rate and breathing rate. And within 60 seconds, within the golden minute, respiratory support should be started if the baby needs positive pressure ventilation during the golden minute. And if you have a pulse oximeter, it should be in place within the first 60 seconds. So the golden minute, I think, is an important aspect here. But Ilkor has forgotten to define when the golden minute is. So I looked up on the literature, I asked people when I traveled around the world, when do you start the clock when the baby needs resuscitation? And there were different answers to that question. Some said when the shoulders are out, some said even when the cord is cut, when the baby is on the resuscitation table. But I think the correct answer is we should start the clock when the whole baby is out. And I think that is of importance because we are doing the 1-minute APGAR score, we're talking about the golden minute, but it's meaningless if we don't know what the golden minute is. And unfortunately, I couldn't find in the new guidelines for 2025 any definition of the golden minute still. So from 2010 to 2015, there was only some minor changes in the algorithm, and that was that this temperature line was introduced to remind us that we should keep the baby normothermic also during the resuscitation. And now the golden minute is not split into 2 parts, it's only 1 part. So, time of birth, we question that, why is it not defined in the guidelines? There was another issue which I think was concerning, and that was in 2015, Ilkor suggested for the first time that heart rate in the delivery room should be monitored primarily by ECG. And I disagreed. We disagreed with this. We wrote a commentary in Acta Pediatrica. I did that with Nicky Robertson and Max Vento. So we disagreed because at that time there were few solid data on this issue, and in addition, most delivery rooms in the world didn't have ECG, and when I travel around, I always ask people, do you have ECG in the delivery room? But very few had that at that time. So we suggested that auscultation should be the primary method still to assess the heart rate. And I also wrote an article with Roger Sol about that, and what we said was that auscultation is still the gold standard for assessing heart rate at birth. Now, in just as a week ago or so, the new guidelines, the 2025 recommendations, ILCOR recommendations, were published. And you see there's a long list of authors here. Helen Liley from Australia is the chair. Anna Solevåg is sitting there, is a member of the ILCOR group. And if you look at the algorithm, it's not been changed since 2015. So very briefly now, I would, if I have time, say a few words about the new guidelines, the new recommendations. I don't have time to go into that in detail. But what was new, I think, is that they now are introducing this briefing before the neonatal resuscitation. In 2015, they introduced debriefing after resuscitation, but now they also suggest that one should do a briefing before, so the neonatal team should communicate with the obstetric and midwifery team to inform about the neonatal management plan. And also, regarding heart rate assessment, I think there's been some improvement. Well, they maintain that ECG, yeah, well, first of all, what they focus on is that we shouldn't fixate too much on heart rate alone, because that, according to ILCOR, could lead to too many or too few resuscitation interventions. But very recently, a study was published testing out a wireless heart rate monitor, the Neobeat, versus traditional ECG registration. And this was a study from Anup Kateria's group in California. You can see it was published in August, very recent. And here you can see they have a scatter plot where they have compared heart rates measured by Neobeat and ECG, and you see there's a very good correlation, 0.96. However, when they looked at babies who were bradycardic, you see there's a different picture. It's a wide scatter. It's not that accurate as when the heart rate is above 100, but still there is a correlation of 0.8 approximately. So ILCOR now says that heart rate measured by ECG is considered the gold standard, but what they also add now is that pulse oximetry and auscultation may be reasonable alternatives to ECG for heart rate assessment. So I think that is an improvement, because they had forgotten auscultation for 10 years. So auscultation with or without pulse oximetry should be used to confirm the heart rate when ECG is unavailable, not functioning, or when pulseless electrical activity is suspected. And now, umbilical cord management, and that is a big chapter, so Chairman, should I skip that and go to a conclusion? What do you think? Yeah? Okay. So then I skip this about cord milking also, and they also have now new suggestions for devices and interfaces, and that's also now, ILCOR is recommending the use of supraglottic devices, which I think is also important as new. Very quickly regarding oxygenation of preterm infants, in the 2015, the latest update was 2018, ILCOR recommended to start out positive pressure ventilation with 21 to 30% oxygen in babies less than 35 weeks. In 2025, they recommend to start with 30% or more for babies less than 32 weeks. And I can mention that the European RDS guidelines, which will be published soon, I'm part of that group, we are actually going to recommend to start out with 60% oxygen in babies less than 28 weeks. So that is new. For babies above 35 weeks gestation, ILCOR still suggests that one should start with 21% oxygen. But what they have removed since 2020 is that you should avoid hyperoxia. Okay, few words about chest compressions and oxygenation. So now, up to now, chest compressions have been carried out with 100% oxygen, but animal experiments done by Anne Solevåg and others, and also a meta-analysis with animal experiments, have shown that it is possible to do chest compressions with air as efficiently as with 100% oxygen, but on NRP. And ILCOR suggests that as soon as you need to do chest compressions, you should increase the FiO2 to 100% oxygen. ILCOR doesn't say which percentage of oxygen they prefer. They only state it is reasonable to increase the supplementary oxygen. But then they say that as soon as heart rate has recovered, return of spontaneous circulation, oxygen should be titrated to oxygen saturation targets. I'm not sure that is a very good recommendation, and the reason for that is based on these animal studies I show here. This is from Lakemin Rushema's lab on newborn lambs. And what you can see here is that this is a model where they had induced cardiac arrest, and then they resuscitated with 100% oxygen, and when they had reached return of spontaneous circulation, ROC, they resuscitated either with, continue either with 100% oxygen and gradually decreased oxygen, or they abruptly decreased oxygen to air. And if you look at this gray, the shaded area here, it represents the cerebral oxygen delivery normal range. And you see the blue symbols here, babies who were given room air immediately after they had accomplished return of spontaneous circulation. And you see that if you're using air, you're in the middle of the target. If you're using 100% oxygen and titrate down, you're way above the target, which may be detrimental. So I think, in my opinion, it's better that as soon as return of spontaneous circulation has been achieved, you should abruptly reduce FiO2 to air. Yeah. Then just a few slides about the future NICU and delivery room, because I think in the future we are aiming at a wireless NICU and a wireless delivery room. I was stimulated, I was at McGill's University a year ago, and together with Northwestern University, where I also have been employed, they're now developing this concept of the wireless NICU. And I think that will be a great achievement, an improvement, and as they said, and we heard already, the age of artificial intelligence is here. So if I can end up this little shortened lecture, newborn resuscitation has the last 30 years become more evidence-based. However, there are still numerous gaps to fill. Most of the recommendations given by ILCOR still are weak, actually a very weak basis for the recommendation. So we need more randomized controlled trials, and newborn care is getting wireless within some years, and artificial intelligence is not coming, it is here already. We also need specific studies in low and middle income countries, and that's urgently needed. We heard that already from several speakers here today, and because we aim at a world where every newborn counts.